Hanji, very good evening, everybody. Good evening. I'm sure you are all fresh and you are all happy to learn. है ना? Do you agree? The most important thing, good evening, everybody. Good evening. So, most important talent that will take you to success is being happy to learn. So I've told you in the my first class itself that there are only two kind of people. People who are happy to learn. The people who are happy to learn will stay young forever. Okay. People who are happy to learn will stay young forever. And people who get angry when they see new things will grow old. So you have to decide and tell me, are you young at heart? Are you happy to learn? Yes? Yes. So if you are happy to learn, if you are young at heart, we will now continue with our today's topic. So you can already see the today's topic is very simple because it is my pleasure that almost all of you have done your surgery classes with us. So there will be some things that you will already be knowing. It will save a lot of time. Today, I just want to do integration of radiology and surgery. I just want to, continue forward on barium studies. You remember in the last class, I talked about barium swallow, barium meal. I want to show you how barium studies look like. I also want to show you how a CT abdomen looks like. And I also want to show you how mammography looks like. Okay. So these are the three things that I want to do in the class today. Barium, CT abdomen, and mammography. And in my last class, which will be on 31st, I will do radiation physics, nuclear scan, PET scan, radiotherapy. Okay, and some of you might have already done this from your lockdown video. So if you have already done this, you can enjoy the holiday. If you have not done it, please attend it again with me. Okay, so everybody understands. So in the last class, we'll look at radiation physics, nuclear scans, PET scan, radiotherapy, for which a video has already been uploaded on your app in the lockdown in the month of March. Okay. So if you remember, if you have already done it, then it is okay. No need to attend it again. But if you have not done it, let's do it together only because you have been kind. We've been able to do it. So we'll try to do that. So today my goal is barium, CT abdomen, mammography. Barium, CT abdomen, mammography. Everybody understands? Okay. Everybody? Okay. A lot of you seem to be asking each other's colleges in the chat box. You're also asking phone numbers. किसी को मदद चाहिए तो मुझे बताएं, मैं मांग लेता हूं आपके बिहाफ पे, है ना? So let's start doing further. Now let's see the next barium image. Okay, let's see the next barium image, and I'm sure most of you will be able to identify this and tell me what we are looking at. Okay. So there is a barium image which I'm trying to zoom, but it's unfortunate. Okay, now see. In this image, I want you to look at the small bowel. In this image, I want you to look at the feathery part of the small bowel. Okay, the feathery part of the small bowel, which is jejunum. ये जितने लड़के टाइप कर रहे हैं ना, इनका कुछ नहीं होगा. ओके बेटे, पढ़ाई में ध्यान देंगे. ओके, एंड दिस इज द फीचरलेस पार्ट ऑफ द स्मॉल बावल विच इज ileum. So that means we are looking at barium meal follow through. Okay, अब बच्चे देखो, you all are thinking that in the exam they will ask you hi-fi things, but in the last year's NEET exam they have shown a barium meal follow through and you had to identify the picture. So it's very important to understand the basics. So if you see only the stomach and duodenum, then we'll call it barium meal. If we follow up after giving barium, we are taking serial X-rays to see the small bowel, then we call it barium meal follow through. And in the small bowel, the feathery part is the jejunum, okay, while the featureless part towards the right side is your ileum. So always remember, the jejunum has complete folds. Jejunum has complete folds, and that is why it is more feathery. Jejunum has folds called as volvulae conniventis. Okay, jejunum has folds called as volvulae conniventis. Everybody clear? Okay. Okay, we are at the first slide, beta. We are at the first slide. Everybody, okay. Now follow up the question with a clinical question now. Now let's understand a tumor which is very frequently asked in pathology in MCQ exams. There is a tumor which is very frequently asked in pathology in MCQ exams. This tumor is called as GIST. Okay, what is GIST? Gastrointestinal stromal tumor. Did you read about GIST in your pathology class as well? Yes, very important. So let's see what is GIST. GIST is a tumor which arises from the interstitial cells of Cajal. Did you read this in pathology? GIST is a tumor which arises from the interstitial cells of Cajal. My question is this, beta. Everybody, let's see if you can answer. If this is your stomach or your intestine, GIST has a growth pattern like this. GIST has a growth pattern which is called as exophytic. GIST has a growth pattern which is exophytic. That means if this is the bowel loop, it grows outward. It grows outward. Now my questions are these. Investigation of choice for a patient with GIST is A, barium meal or barium meal follow through. Yes or no? Okay. Investigation of choice for GIST is barium meal. Yes or no? What do you think? The answer is no. You have to tell me why. Why barium is not the answer here? That is where the mistakes happen in the exam. Barium you are giving orally. So when I am drinking the barium, I can see with the barium the luminal part of the bowel, while GIST is a extraluminal tumor. GIST is not within the lumen, it is outside the lumen. Second question, beta. Let's see if you can answer. The investigation of choice for a gastrointestinal stromal tumor is endoscopy. Right or wrong? Again wrong, because endoscopy can only look at the lumen. It can see the lumen. It cannot show you the exophytic part. Answer is contrast enhanced CT abdomen. So when we do a cross section of the abdomen, with a CT scan, we can see the lumen also, we can see the outside the lumen also. And this is where most people do mistakes in the exam. Investigation of choice for GIST is contrast enhanced CT. Why? Because it is a exophytic tumor. Okay. On a CT scan, GIST will show two features which are typical to GIST. Number one, no bowel obstruction. A gastric carcinoma will cause bowel obstruction, while GIST will not cause bowel obstruction because it is exophytic. Number two, no lymphadenopathy. So you can see now one concept and we are able to connect the entire chart. No lymphadenopathy. Why no lymphadenopathy? Because this feature helps us to differentiate from gastric lymphoma. Did they teach you in pathology that you can have extranodal sites of non-Hodgkin's lymphoma, including stomach, Stomach is one of the sites where you can have GIST also, you can have lymphoma also. So remember now, gastric carcinomas will cause bowel obstruction. Okay, while gastric lymphomas would have lymphadenopathy. GIST would purely be an exophytic tumor with no bowel obstructions, no lymphadenopathy, investigation of choice, contrast enhanced CT. Everybody understands? Clear? So that is where, the understanding comes into the play. I come back to the image. So for those of you who are asking which page, we are only at the first page. We just saw a normal barium meal follow through, and I discussed that how do you identify jejunum? Jejunum will have complete folds that is giving rise to a feathery appearance, okay, while the ileum is featureless. Everybody understands? Okay, now second question. Now identify the image that I'm showing you. Now in this image, you can see that these bowel loops have incomplete folds. The folds are like this. These folds are incomplete. These incomplete folds are called as Hostrae. Okay, so if you see Hostrae, that means we must be looking at the large bowel. This is a barium enema. Okay, this is a barium enema because you can see the sigmoid colon, the descending colon, the transverse colon, the ascending colon. So you can see different parts of the large bowel. So if you see large bowel but you do not see the small bowel and you do not see the stomach, if I am unable to see the stomach and the small bowel, then how barium has gone into the large bowel? It has gone not orally, it has been given, tell me, through the enema. You have given a enema to the patient and hence you are unable to see the stomach and the small bowel. This is a barium enema. Okay, remember, out of the 4 barium investigations that I have taught you, barium swallow, barium meal follow through, barium enema. Barium enema has maximum radiation exposure. Can you remember this? Which barium study has highest radiation exposure? The answer is barium enema. Okay. So Sri Lakshmi, I hope when you were in anatomy, Sri Lakshmi, you might have seen jejunum has complete folds called as volvulae conniventis, while in large bowel the folds are incomplete. They are called as Hostrae. Okay. So if you see Hostrae, that means we are looking at large bowel. Okay. Now let's see if you can answer. Okay. Now let's see some abnormalities. First image. Let's see. Identify the investigation and the abnormality from your surgery class. Okay, simple thing, you will always study about this definitely in surgery. I am just, trying to give you a complete picture here. So this is a barium swallow. What is the abnormality in this barium swallow? The esophagus is grossly dilated. The esophagus is grossly dilated. What are these filling defects? Can you see the esophagus is dilated, but there are some areas in the esophagus where you cannot see the barium going in. The barium cannot go there. Those are the food residues. Those are your food that the patient has eaten. There are some food residues. And then I can also see the esophagus in the distal part is becoming narrow, just like a bird beak or like a rat tail. This is called as achalasia cardia. This is called as achalasia cardia. Again, this is one of the most frequently asked visuals in your exams. Very simple. You should see it once, then you will never get it wrong. Investigation of choice for achalasia cardia is barium swallow. Okay. But if they say what is the best investigation, please mark manometry. Are you clear? Investigation of choice for achalasia cardia is barium swallow, but if they say best, please mark manometry. Now, what are we supposed to differentiate it from? Achalasia cardia should be differentiated from the next picture. Okay, let's see how many of you are able to answer and tell me. Suppose this is your esophagus. It is not that dilated. Abruptly, suddenly it becomes narrow, and then you have an irregular narrowing, and then there is a sudden change again. Such an appearance is called as shouldering or we will call it as apple core. So in bowel, whenever we use apple core word or shouldering, we usually mean a malignancy. And this narrowing is also called as rat tail appearance. What are we looking at? CA esophagus. So I think you have already studied this in surgery and you're all excited about this. So I will just reduce the size a little bit. Okay, the question number 1. So there is no role of radiology in diagnosing CA esophagus. Today, CA esophagus is usually diagnosed on endoscopy and biopsies. The role of radiology in CA esophagus is in staging. So whenever they ask you, what is the staging investigation to be done in CA esophagus? What is the staging investigation to be done in CA esophagus? The answer is PET-CT. The answer is PET-CT. But if they say T staging, or if they say local staging, then what will you mark? You will mark EUS. For the children who do not know EUS, what is EUS? EUS is, tell me, endoscopic ultrasound. Endoscopic ultrasound. Are you clear? Okay. So these are the only 2 radiology questions to be remembered here. For local staging, endoscopic ultrasound is better than PET-CT. Okay. Not only ultrasound, you have to say endoscopic ultrasound. The ultrasound machine, which is used while endoscopy to see the depth of penetration of the tumor in the esophageal wall. Are you clear? Okay. So now see. So these are 2 commonly confused things. CA esophagus, achalasia cardia. Now I will show you one more picture that you already know of. What do you think this is? This is what is called as the cork screw esophagus. Okay, this is what is called as corkscrew esophagus. You can see multiple non-propulsive contractions in the esophagus. This is called as diffuse esophageal spasm. Very good. And this is the image that I've taken from NEET PG 2019. So keep it in mind that whatever I'm showing you is asked in the exam. Many students, they get confused that, sir, what do I have to study for the exam? Whatever I'm teaching you, that is all that you need to study for the exam. The exam will be from your class notes. Okay, because why? Because we have covered everything needed. Okay, so this is the resource that you need to trust. When you trust, then you are able to revise it multiple times. But if you do not trust, then you keep buying new resources and you keep wasting time. So please trust the resource that you have and do multiple revision. The exam will be from your class notes. Whatever we are teaching will be asked in the exam. Okay? Everybody understands? Okay. Now let's go further. Now again another barium swallow image. Now what do you see? Now in this patient, in the esophagus, there is a filling defect. Filling defect matlab jahan barium nahi ja pa raha. Filling defect means the area in which the barium cannot enter. This filling defect is smooth. Okay? And is not obstructing the lumen. If you notice, the esophageal lumen is preserved. There is no obstruction to the pathway of barium. The barium is passing through like this. There is a filling defect, but it is not obstructing. Is it a carcinoma of the esophagus? Yes or no? Is it a esophageal carcinoma? No. Why not? Why this is not a esophageal carcinoma? Because it is smooth. Cancer will be irregular. Number two, there is no obstruction. Cancer will cause stenosis. We know it by now. Carcinomas in the bowel will encircle the like an apple core like this, and it will cause obstruction. So then we think of benign disorders like submucosal disorders like leiomyoma. Okay. So if you see in the exam esophagus showing a smooth filling defect with no obstruction, eccentrically placed, this is the filling defect, then you think this is a leiomyoma. Are you able to understand the thinking process? Okay. So if you notice now, I am showing you some abnormal pictures of esophagus. Gradually, I will show you some abnormal pictures of stomach and some abnormal pictures of intestine also, so that we are able to complete the discussion. Okay. Now, any one of you can identify this picture. Now, normally in the esophagus on a barium study, you should see longitudinal folds. So I'm writing longitudinal folds in esophagus are normal. But in this patient, the folds that you see in the esophagus are transverse. In this patient, in the esophagus, you can see transverse folds. Transverse folds are not normal. Okay. Longitudinal folds in esophagus is normal. Transverse folds are abnormal. Transverse folds are seen in the esophagus of the cat. Transverse folds are seen in the esophagus of the cat. Everybody understands? Everybody understands? So if I now call this esophagus as catty esophagus, catty, it does not sound good. So now we use the family name here to give respect to the cat. We say feline means cat esophagus. This is called as feline esophagus. What is feline esophagus? Prominent transverse fold in the esophagus. Seen in? So what happens is it is seen in patients with GERD. What is GERD? Okay. What is GERD? Tell me. GERD is gastroesophageal reflux disease. Gastroesophageal reflux disease. This means that when the acid from the stomach goes into the esophagus, it causes a contraction and spasm of the muscularis mucosa. Acid reflux causes spasm of the muscularis mucosae. Because of that muscularis mucosae getting contracted, you develop transient folds, which is called as feline esophagus. But don't forget, another cause of this appearance is eosinophilic esophagitis. In eosinophilic esophagitis, the folds are more permanent. So if they ask you the difference between the two, please remember, in GERD, the folds are transient. In eosinophilic esophagitis, the folds are permanent. So we also use a term here called as trachealization of esophagus. If the esophagus looks like trachea with rings, so we might use the word ringed, then think of eosinophilic esophagitis. Permanent folds are seen in eosinophilic esophagitis. Transient folds are seen in GERD. Ringed esophagus, trachealization of esophagus, eosinophilic esophagitis. Okay. Only once in 2019 in NEET exam they did a mistake, and the exam body they gave both as choice. GERD was also written, eosinophilic esophagitis was also given. So for feline esophagus, single best answer is GERD, because this is where we first described this appearance was described in GERD. Everybody understands the concept? Everybody understands the clarity? Okay. Now please see. Some of you are thinking that this must be some veterinary doctor who has told you all this. No. So please see. Earlier, doctors were free. In earlier times, in early 1900s, okay, let's try to understand. In early 1900s, the doctors were free. Why? Because we had no drugs or no treatments. So many of the doctors were also doing animal experiments. Okay, many of the doctors were also doing animal experiments, and all these terminologies are because of that era. You might have heard of how when the first heart transplant was done by Bernard, you might have read about him in school. Now in college you are no longer reading, but remember in school you were so inspired by all those stories. But then they first did heart transplant in animals, and then they came on to humans. That is how the things go. So don't think that only the veterinary doctors know about animals. It's not like this. Okay. So these are the only few images about esophagus that we need to know. Okay, let me ask you another question now. What about stomach? The most important question in stomach is a disease called as CHPS. Okay, most important disease. Okay. Okay. Yes, Hamilton also you know about it. Very good. So now see CHPS. What is CHPS? Congenital hypertrophic pyloric stenosis. Investigation of choice for CHPS is tell me. Answer is ultrasound. This is one of the indications where in bowel the answer is ultrasound. Usually when it comes to bowel, we think about, okay, listen to me, beta, listen to me. Usually in bowel, okay, so I'm writing the full form for the chota wala bachas, congenital hypertrophic pyloric stenosis. But remember, usually all the bada wala bachas, remember, usually in bowel we will go for things like endoscopy or barium, but CHPS is a question where you will mark ultrasound as the IOC. Another point I wanted to make here was, which is a potential question for you, is most of the time if a patient has acute abdomen in an adult, most of the time if I don't know the diagnosis, if I don't know what is the cause, I only know patient has abdominal pain, unbearable abdominal pain, then I go for contrast enhanced CT. But in children, in acute abdomen, also IOC is ultrasound. Now name two conditions where ultrasound is marked as the answer in abdomen: congenital hypertrophic pyloric stenosis, acute abdomen in a child. Acute abdomen in a child, please mark the answer as ultrasound. So now let's see how exams are structured. In PGI Chandigarh recently, they asked a question, why ultrasound is preferred in children with acute abdomen? The question is why? Okay. Again, you will notice the same concept that I taught you in my class. I taught you that we need to explore why. Okay, adult में हमने बोला if it's an adult with acute abdomen नहीं पता चल रहा क्या है तो CT कर लो, बच्चे में ultrasound. Why? The answer is no radiation exposure. Because ultrasound is based on sound, it has no radiation exposure. It is preferred in children and pregnant ladies. Very good. But the problem in PGI is more than one answer is correct. PGI के अंदर तो एक से ज्यादा आंसर सही होगा. अब क्या करें? Anybody? So PGI में you will always see the examiner will keep saying और बताओ. आपने एक आंसर बताया बोलेगा और बताओ. So the second reason is, anybody? Ultrasound does not need sedation. This is very important for you to understand. When you are doing CT scan in an adult, the patient has to lie down still. But children will not lie down still. So do we need to give them sedation so that they can be, still? Okay. But ultrasound is easily doable. You can have the child in the mother's lap and mother will comfort him and you can do the ultrasound without any sedation. Okay. This is a very important question. And number three is, okay. Number three is slightly conceptual to understand. Let us try to understand the concept here. Let's see if you can answer. Beta, please think and answer, beta. Think and answer. Okay. Any one of you can answer, beta. The abdomen of a child is very small. The abdomen of a child is very small. Everybody understands? Yes. Very good. Now tell me. But when you grow up, your abdomen becomes big. So now let's understand. In child, because the abdomen is of small size, we can use high frequency ultrasound. Anybody can tell me the advantage? High frequency means low penetration, but high resolution. Clear? Are you able to think about it or not? As you grow up, because of the mistakes that we do in life, your abdomen becomes like this. You understand the concept now? So this is where PGI Chandigarh becomes a special exam. Remember, PGI has a concept of more than one answer correct. So you need to think on each choice as is true or false. Okay, so this is how the questions are. It is very simple question, simple concepts, but you will have to think properly. Otherwise, you will not be able to get into the top ranks in PGI Chandigarh. Are you clear with the example? Okay, very good. Everybody understands the concept. Now, let me show you a visual and let me ask you a question on a visual. Okay. Now look at this visual and tell me, is this a barium meal showing you CHPS? Yes or no? Is this a barium study showing you CHPS? Yes or no? Okay. Atul beta, last time I told you na, higher the frequency in ultrasound ulta hota hai, likha nahi tha kya? Okay. Okay. Now tell me beta, listen to me and answer beta. Okay? Barium meal CHPS is not possible. This is not CHPS. Why? Because you can see the stomach, see the proximal part of duodenum, a little bit of duodenum becoming like this, distal part is becoming like this, and then you see a little bit of jejunum, but then the barium is unable to go further than this. You see a little bit of barium, but it is trickling down. Okay, so had it been CHPS, you should only see the stomach. How you are able to see the jejunum? What we are able to see in this patient is, we are able to see a corkscrew appearance of duodenum and proximal jejunum. The duodenum and the proximal jejunum is becoming like a corkscrew. What is this? Now, some of you are saying this is duodenal atresia. Some of you are saying this is duodenal atresia, which I don't agree. Tell me why. Duodenal atresia will show you a X-ray abdomen with two gas bubbles, one in stomach, one in duodenum like this. What is that? It should show you double bubble appearance. This is not duodenal atresia. Duodenal atresia should have double bubble appearance. Now what happens is, can any one of you tell me, in a normal person, if this is right side, this is left side, tell me, jejunum should have been on the left side. But in this patient, the jejunum is on the right side. Can you tell me why? Can you think of a reason why would you have jejunum on the right side? Jejunum is on the left side. Why the jejunum of this patient is on the right side? Anybody? This patient has malrotation. This patient has malrotation. Now, if I ask you a question now, children who have malrotation, what is happening in malrotation is, listen to me, let me just increase the size here. Please see and understand. In malrotation, what is happening is, if this is my stomach, my duodenum, jejunum. So jejunum should have been on the left side. In malrotation, jejunum is on the right side. So the DJ junction, the DJ flexure, duodenojejunal fracture, is on the right side of the spine. So the distance between the ileocecal junction and the DJ flexure is shortened. In malrotation, the distance between the DJ flexure and the ileocecal junction, where you have the mesenteric attachment, is shorter. So children with malrotation have shorter mesenteric attachment. Okay. Now think of it and answer, beta. Think of it and answer. Okay, listen to me. I'm sure you will be able to answer. If your bowel loops are hanging on a narrow rope, एक पतली रस्सी पे, now a mesenteric attachment is narrow in malrotation, so bowel loops will be hypermobile. If the small bowel loops are hypermobile in a child and if they twist on their own axis, that is called as midgut volvulus. And the appearance is called as corkscrew appearance of duodenum. Are you clear now? Corkscrew appearance of duodenum is seen in, okay, it is seen in midgut volvulus, and children with malrotation are particularly predisposed to develop midgut volvulus. Everybody understands? Because of the reason is believed to be shorter mesenteric attachment in children with malrotation. So the answer is midgut volvulus. Very good. I can see many of you are able to answer. So you can now see that what we are seeing in the images is all interlinked to what you have studied in surgery. We are just trying to cover up the barium images. Okay. Any one further question for you? Let's see if you can answer. Now, if we now go on to stomach more, in stomach, one of the disease that we all need to talk about is ulcer. In stomach, you can have a gastric ulcer. Now, any one of you can tell me, gastric ulcers can be benign peptic ulcers, or in stomach you can have cancers which will be called as malignant gastric ulcers, or we will use a word CA stomach. Everybody understands the difference between the words? Benign gastric ulcer ko, okay. So, okay, everybody understands? Now I've repeated it for you again. So, benign gastric ulcer ko, we can call it as peptic ulcer. Malignant gastric ulcer is called as CA stomach. So, I'm sure with your knowledge of surgery and pathology, you might have heard of this already, that peptic ulcers are mostly seen in the duodenum, in the first part of duodenum called as the duodenum bulb or duodenal cap. Okay, so most of the time peptic ulcers are seen in the duodenum bulb or duodenal cap. Gastric ulcers are of two types, benign और malignant. ड्यूडनम में ज्यादातर बिनाइन ही होंगे, लेकिन स्टमक में बिनाइन भी हो सकते हैं, malignant भी हो सकते हैं. Everybody understands this reason? Okay. Now I will try to show you how to identify a benign ulcer on a barium study. Now suppose this is an ulcer in the stomach. Suppose I am trying to draw an ulcer in the stomach. What is an ulcer? Ulcer is a defect in the mucosa. भाई acid के कारण mucosa में defect हो गया. So the barium that I am giving orally will fill up into that defect. Okay. अब आपने बताना है, think of it and answer. Wherever you have a ulcer in the stomach, एक जगह जब चोट लगेगी, ulcer is a injury that has happened. How will the body respond? Body will respond by scarring. You remember I told you, चोट लगेगी, बाद में fibrosis होगा, chronic inflammatory change होगी, there will be scarring. So if there is a scarring there, if the ulcer has fibrosis, the ulcer will retract. When the ulcer retracts, it pulls the gastric folds towards it. Okay. So that means I can safely write a line. In a benign gastric ulcer, gastric folds radiate from the ulcer margin. Benign gastric ulcer में gastric folds ulcer margin से radiate करेंगे. So ध्वनि बेटा, previous image was midgut volvulus. I told you ना, CHPS भी नहीं है वो, और ना ही duodenal atresia, that is midgut volvulus. ध्वनि, okay? Everybody clear now? Okay. Now let's see if you can answer beta. Okay. Now listen to me and answer beta. Many of you are thinking that all the children who are listening today, they are all thinking that if sir is telling that whatever he is telling will come in the exam, then how the difference will be, like you are all hearing me, then who will get a better rank? So the problem is, despite hearing, many of you, they do not understand. So that's a problem. So what is important is that you need to revise the things, you need to read it again, you need to apply them on the DQB to improve your understanding levels. And then the competition, you become better in the competition. It is not about, redoing everything from multiple sources. It is about revisiting what I have told you. Every time you will revise your notes, you will find something extra in them. Okay, that's very important. Now see with me, beta. See with me. Now suppose, everybody see with me. If this is a ulcer in the stomach where the barium is collecting, are you able to see that these are all gastric folds which are converging onto it? What is this? This is a benign peptic ulcer. Okay, same thing is written in your pathology book also. In a benign peptic ulcer, gastric folds will be seen converging onto it. Some of you might be wondering, sir, ये fold white और black क्यों दिख रहे हैं? बेटा imagine ना, fold में जो उठा हुआ भाग है उसमें बेरियम नहीं जा रहा, जो दबा हुआ भाग है उसमें बेरियम जा रहा है. So now in the stomach, the elevated part, the barium is not getting in, while the depressed part of a fold is having barium, giving rise to this kind of appearance of black and white. Everybody understands? Everybody follows? So this is benign gastric ulcer, beta. Okay. Second question. What if it was a cancer? If a ulcer is in a cancer, if it is a malignant ulcer, then that ulcer should be surrounded by heaped up margins. Do you remember, did they teach you in surgery heaped up, rolled up margins? Malignant ulcers have a heaped up, rolled up margin. So the gastric folds can only reach up to here. So that means what you need to write down in your notebook is malignant ulcer, the gastric folds do not reach the ulcer margin. In malignant ulcer, the gastric folds do not reach the ulcer margin. Okay. ड्यूडनल कैप में ज्यादातर पेप्टिक अल्सर, बिनाइन अल्सर ड्यूडनम में दिखता है बेटा. Okay, everybody understand? Arka Provo Mukherjee beta, are you able to see this? That peptic ulcer ज्यादातर duodenum में benign मिलता है. Stomach में ulcer होता है, तो it can be either benign or malignant, and we need to differentiate. And that is why it was written in your pathology book also, how to differentiate a benign ulcer from a malignant ulcer. आपने second year में difference between लिखा भी था, prof में बेटा भूल गए. हाँ? Now see, the second thing to understand is, so far we were looking at an ulcer from front. Now I will look at an ulcer from profile. Okay, in profile. Please see with me. If this is your stomach, and you can see the barium is inside the stomach, if you have a benign gastric ulcer, you will see a outpouching. You will see a outpouching. Benign gastric ulcers are seen as outpouchings. क्यों? क्योंकि बेरियम आपने ल्यूमन में लिया. So if there is a defect in the mucosa, the barium will go into it. It will appear as if it is protruding out. And a long-standing duodenal ulcer will lead to scarring, and this is called as trifoliate duodenal cap. Okay, so if you have a benign duodenal ulcer, it will look like, it will become a trifoliate appearance, and a benign ulcer from the stomach will be seen as a outpouching. So these are the words to keep in mind to understand that I'm talking about a benign ulcer. A malignant ulcer, on the other hand, is actually a CA stomach which has ulcerated. ओके हाँ बेटा, जो बेरियम दिखाए बेटा मैंने, ये दोनों बेरियम बिनाइन है. जो डायग्राम बना रहा हूं वो मेलिग्नेंट है. सो मेलिग्नेंट इज द डायग्राम दैट आई एम शोइंग यू, बिनाइन इज द बेरियम इमेज. प्लीज सी विद मी नाउ बेटा. सो इन अ सीए स्टमक, this is how a tumor should be in the stomach. Okay, tumor है. Now the tumor has some hypoxia in the center leading to some ulceration. उसका blood supply center से outgrow हो गया, center में ulcer हो गया. So this is how a malignant ulcer will be. Malignant ulcer is actually a patient with CA stomach where the surface of the tumor has ulcerated. Now if I give the patient barium, everybody focus and understand, if I give the patient barium, what will happen? The barium will go into the ulcer, but it will not go into the tumor. It will go into the ulcer, it will not go into the tumor. So when you will take an X-ray of this patient, the X-ray will look like this. So what will happen is, you will see that this is the malignant ulcer. It will have margins which are convex towards the gastric lumen. Margins of a malignant ulcer are convex towards the lumen of the stomach. These are the margins that I'm talking about. These convex margins are called as meniscus, described by a radiologist called as Karman. So we call it Karman's meniscus sign. This is what is called as Karman's meniscus sign. Okay. Everybody understands? So what will happen here is, try and imagine now, I will again repeat it for you. In this page, all you have is difference between benign and malignant ulcer. Benign ulcer, gastric folds will be seen radiating from the ulcer margin. Malignant ulcer, gastric folds cannot reach the ulcer margin. Benign ulcers will be seen as a outpouching, and you can also see duodenal deformity called as trifoliate duodenum because of chronic duodenal ulcers, which are benign. Malignant ulcers will show margins which are convex towards the lumen of the stomach, which is called as Karman's meniscus sign. Everybody understands? Okay. Now, once you are able to follow this, okay, once you are able to follow this, okay, listen to me now. Now I am showing you a X-ray which is very often repeated, very often repeated, बेटा, है ना? एक ऐसा X-ray देखो जो बहुत बार पूछते हैं बेटा. Anybody? It's a complication of perforation. What do you think? क्या ये? This is pneumoperitoneum. Many people miss it because they keep looking at the lungs and they miss below the diaphragm. What is this? This is gas below the diaphragm. Pneumoperitoneum. Are you able to see now? Okay. And even in the AIMS exam, they keep asking this, and many children, they miss it on the exam day. अभी सब दिखाई दे रहा है क्योंकि मैं दिखा रहा हूं. ओके, बाद में जब खुद देखना होता है तो मिस हो जाता है. That is why you need to revise. So what happens is, whenever teachers are teaching you, listen to me very carefully. Whenever teachers in dams are teaching you, it will always appear as if everything is simple because these people have been teaching for decades. Okay. But when you go and do it yourself, sometimes you will not be able to do it in one go. So revise again, okay? Don't miss out on revision. Don't get pseudo confidence that अभी सर ने बताया तो मैं सब कल जाके मैं अपना हॉस्पिटल में सब कर लूंगा. इतना आसान नहीं होगा, because when we are showing things, it will look easy. That is where your goal of revision should be there, beta. Don't forget about it. Okay? Now tell me. So very often asked MCQ in all the exams in the world is, what is the best X-ray to detect pneumoperitoneum? What is the best X-ray to detect pneumoperitoneum? बेटा बताएं. Best X-ray to detect pneumoperitoneum is chest X-ray erect. You might have noticed, बेटा, you might have noticed, देखो कि राइट डायफ्राम के नीचे गैस नहीं होता. अगर है तो इसका मतलब ये न्यूमोपेरिटोनियम है ना? सो बेस्ट एक्सरे टू डिटेक्ट न्यूमोपेरिटोनियम इज अ चेस्ट एक्सरे इरेक्ट. सेकंड क्वेश्चन, व्हाट इफ द पेशेंट इज बेडरिडन? You are suspecting pneumoperitoneum, but the patient is bedridden. Then what will you do? Now, if the patient is bedridden and he cannot stand up, then the next X-ray to be done here is left lateral decubitus. You will make the patient in the left lateral decubitus position. उसको लेटे लेटे ही left curved पे लेटा देंगे to look for gas on the right side. Are you clear? Should I repeat? Are you clear? So best X-ray for pneumoperitoneum is chest X-ray erect. If that is not possible, then please mark left lateral decubitus. Do not mark abdomen erect as the answer here. I am making it as a cross. Most people, what happens in the exam is, the exam will say, what is the best X-ray for pneumoperitoneum? They will think, in हवा peritoneum में देखनी है तो abdomen का X-ray करते हैं. जबकि gas below the diaphragm is best seen on a chest X-ray, not on a abdominal X-ray. Okay, everybody understands? Why right lung is not there? Lung तो है ना बेटा, this is lung बेटा. What is your doubt? ये लंग है बेटा, ये पतला सा व्हाइट सा जो दिख रहा है बेटा, ये डायफ्राम है. नाउ डू यू सी इट? ये नहीं दिख रहा. कैन यू सी द डायफ्राम इज आउटलाइंड बाय द गैस बिलो इट? ओके, देन सम ऑफ यू आर थिंकिंग, सर ये तो नहीं है गैस. नहीं बेटा, ये तो गैस्ट्रिक फंडस है, इसको मत कंफ्यूज कीजिए. दिस इज गैस्ट्रिक फंडस. देन सम ऑफ यू आर आस्किंग, सर व्हाई लेफ्ट? व्हाई लेफ्ट लैटरल डिक्यूबिटस? व्हाई नॉट राइट? Anybody wants to answer? Beta dekho, air always rises up. Okay, air always rises up. Try and understand beta. Okay, try and understand. Air always rises up. If I make the patient lie down on the left side, the air will rise up to the right side. Right पे तो हवा होती नहीं. If I see air, that is pneumoperitoneum. Now, if I make the patient right lateral decubitus, patient lies down on the right side, gas will go to the left side. Left पे तो gastric fundus होता है. Okay, and you will get confused because of the gastric fundus. That is why left is considered better, so that you don't get confused. Okay, everybody understands? You don't get confused with the gastric fundus. Okay, very good. Now let's see if you can answer. Now, what if you have a anatomical variant? What if you have a anatomical variant called as Chilaiditi syndrome? Where you have your hepatic flexure of the colon between liver and diaphragm. Okay, let's see if you can answer better. I'm sure आप बता पाएंगे. Normally, hepatic flexure is below the liver, but in an anatomical variant called as Chilaiditi syndrome, hepatic flexure is seen between liver and the diaphragm. What is the problem in this anatomical variant? This is a cause of, anybody knows? This is a cause of pseudo-pneumoperitoneum. अगर किसी का नॉर्मली राइट डायफ्राम के नीचे बावल नहीं होना चाहिए, अगर है तो you might mistake it for pneumoperitoneum because it is a anatomical variant not commonly seen. If that is why it is called as Chilaiditi syndrome. So what is Chilaiditi syndrome? It is a cause of pseudo-pneumoperitoneum. It is an anatomical variant in which the hepatic flexure of the colon is between liver and diaphragm. Very good. I can see most of you are able to answer. Now, let's see and look at this picture and let's look at it together. Okay. Anyone? X-ray of an adult or a child? Okay. This is an X-ray of an adult or a child. This is the X-ray of an infant. You can see the femur has not, the head of the femur has not appeared. Is it a normal X-ray or abnormal X-ray? Is it an erect X-ray or a supine X-ray? Remember, in infants, we always do supine films for common sense. Understand? An infant comes to you, a small infant comes to you, and you are telling him, "जाओ सीधे खड़े हो जाओ." वो देख रहा है आपको कि कहाँ से आया डॉक्टर. You remember कि नहीं? Infants, we always do a supine plane. Okay, we will not ask him to go and stand erect to get an X-ray done. It's a supine film. So in the supine film, when I'm lying supine, the air will rise up. Okay, if I have perforation, why would an infant have perforation? Infant, you might have studied in pediatrics a condition called as necrotizing enterocolitis. So if an infant has necrotizing enterocolitis, there will be perforation. Okay, there will be perforation. Everybody understands. So if there is a perforation because of severe necrotizing enterocolitis, there will be air leaking out of the bowel and fluid will also leak. Okay, the air will rise up and the bowel loops will float in the fluid towards the center. Please see with me. Now try and understand. This is the shadow of the infant's liver. This is the bowel loop. Just look at this area that I'm marking for you. ये area को देखना बेटा. ये. Okay. Now tell me, the area that I have marked for you, is that bowel? नहीं ना. It is not taking shape of a bowel. This is free air. So that means in a infant, in a supine film, if you have pneumoperitoneum, the X-ray will show air like this. Can you see the air? Why not in the center? Because in the center, the bowel loops and the liver are, anybody, floating to the center of the child's abdomen. So this is looking like this. What is this? This is American football. So we call it as football sign. Okay. So sometimes they might ask you a question, football sign in X-ray abdomen, or they might show you a X-ray like this and asking you what is the finding. This is pneumoperitoneum. Everybody understands? Pneumoperitoneum. Okay. This is called as pneumoperitoneum. Anybody understands? So please remember, not always you will see gas below diaphragm, because gas below diaphragm is seen in erect position. In infants, when they have perforation, the supine plate will show you, anybody, football sign. Okay, everybody clear? Pneumoperitoneum on X-ray of an infant will look like a football sign. Okay, another question. Can you see on a X-ray? Can you see on a X-ray abdomen ligaments like falciform ligament? Can you see on a X-ray abdomen your umbilical ligaments? The answer is no. We should not be able to see ligaments on a X-ray. Okay, just theory to remember, just theory, no visual here, just some theory to remember. What if you see falciform ligament on X-ray? What if you see air outlining your umbilical ligaments like this, which is called as the inverted V sign? So if there is air in the peritoneum, this peritoneal air will outline the peritoneal fold ligaments like falciform ligament, like umbilical ligaments. So if ever you see a question saying falciform ligament sign seen in, umbilical ligament getting outlined giving rise to inverted V sign seen in, the answer is pneumoperitoneum. Everybody understands the question now? Are you clear? So normally these peritoneal fold ligaments like falciform ligament and umbilical ligaments are not seen on X-ray, but when they are outlined by air in the peritoneum, then we use terms like falciform ligament sign and inverted V sign. Another question that I wanted to bring to your notice is, if this is an X-ray abdomen, and if on the X-ray abdomen you see air below the central tendon of the diaphragm, if you see air below the central tendon of the diaphragm, we use a word, only the names are important for you, cupola sign. If we see air below the central tendon of the diaphragm, you will use a word, cupola sign. Can you recall where did I teach you continuous diaphragm sign? उसमें हवा ऊपर थी डायफ्राम के, है ना, इसमें नीचे. Continuous diaphragm sign was pneumomediastinum. Cupola sign is pneumoperitoneum. Okay, one more thing to remember, just one more to remember. This was asked in 2019 PGI exam. If these are your bowel loops, okay, and in one of the bowel loops there is perforation and only small amount of air leaks out and then it is sealed, so that small amount of air can form a triangular pocket of air between the bowel loops. This is called as telltale triangle sign. Okay. Ishika Singh is asking how to differentiate pseudo pneumoperitoneum from true pneumoperitoneum. Beta Ishika, remember, pseudo pneumoperitoneum, you have hepatic flexure below the diaphragm. Hepatic flexure is colonic loop. Colonic loop will have, tell me, haustray. So you will see in the air some folds will be visible. Haustray will be visible to help you differentiate. Okay. Now let's see if you can answer better. Now I am going to revise for all of you. Name some named signs of pneumoperitoneum. Football sign, falciform ligament sign, inverted V sign, cupola sign, telltale triangle sign. Free air trapped between the bowel loops can look like a triangular pocket of air, which is called as telltale triangle sign. Okay, now let's see one more X-ray. Cupola is air below the central tendon of the diaphragm. Okay, Raji? Okay. Okay, now I'm going forward. I'll show you one or two more images to understand, then we'll talk about it more. Now, normally, whenever you look at an X-ray abdomen, you have air inside the bowel loop. This air inside the bowel loop outlines the mucosal surface of the bowel. मतलब बावल के सरफेस, इनर सरफेस होता है म्यूकोसा, आउटर होता है सिरोसा. So remember, air inside the bowel loop will outline the inner wall of the bowel. लेकिन अगर परफोरेशन है तो if you have perforation, then air is seen both inside and outside of the bowel loop. Okay, perforation है तो हवा अंदर भी है बाहर भी है. So now I'm saying, if you see air outlining both sides of the bowel wall, it must be pneumoperitoneum. This is what is called as Wriggler's sign. If you see air outlining both sides of the bowel wall, it is called as Wriggler's sign. Normally सिर्फ बावल की अंदर की तरफ हवा होनी चाहिए, वॉल के बाहर नहीं होनी चाहिए. अगर दोनों तरफ हवा दिख रही है, that is called as Wriggler's sign. That is a sign of pneumoperitoneum. Okay. Yes, all these are signs, Rajal, Jani, these are all signs of pneumoperitoneum that I'm teaching. But then, why would you get it wrong in the exam? Okay, let's see if you can answer. I'm writing a confuser. Let's see how many bada bachas, people who are appearing for the exam this year, are able to answer this or not. Very important. Did you read in surgery something called as Wriggler's triad? ओके, मैंने बोला रिगुलर साइन तो न्यूमोपेरिटोनियम में है, रिगुलर ट्रायड कहां होता है? रिगुलर ट्रायड, एनीबडी? डिड यू रीड अबाउट रिगुलर ट्रायड एनीवेयर इन सर्जरी? Wriggler's triad was seen in gallstone ileus. Remember, gallstone ileus में एक्सरे में आपको तीन बातें दिखेंगी. What were these? Pneumobilia. You will see air in the biliary tract. Number 2, small bowel obstruction. SBO मतलब small bowel obstruction. And you will be able to visualize a gallstone in the bowel loop. So are you clear that this is where mistakes happen? Wriggler sign is seen in pneumoperitoneum. Wriggler's triad is seen in gallstone ileus. It has three parts: pneumobilia, small bowel obstruction, and a gallstone. Very good, beta. I can see all of you are able to answer. Now what we will do is we will look at a CT scan of the abdomen and we will try to evaluate it together. This is my prediction for your upcoming NEET exam. Let's see if you are able to pick it up or not. This is your liver on the right side. This is your right side. This is your left side. This is your right kidney, left kidney, aorta, IVC. For the people who are interested in anatomy, you can actually see one branch of aorta here This branch is your superior mesenteric artery. Along with the superior mesenteric artery, you will see a vein. This is how it is oriented. This is your superior mesenteric vein. Okay. And in between the superior mesenteric artery and the aorta, you have your left renal vein going into the IVC. Okay. सो पूजा आई होप यू सी रेगुलर साइन में बेटा मैंने बोला बावल वॉल की दोनों तरफ है ना, एक तरफ म्यूकोसा है, दूसरी तरफ सिरोसा है. हवा सिर्फ म्यूकोसल सर्फेस के साथ होनी चाहिए. एयर शुड ओनली आउटलाइन द म्यूकोसल सर्फेस, नॉट द आउटर सर्फेस. If you see it outlining the serosal surface also, then we call it pneumoperitoneum. Okay. So this is the anatomy that I want you to see. Now, anybody, look at the image again and tell me where is the abnormality? Where is the abnormality? In this X-ray, I want to take your focus here. In this CT scan, please take your focus here. What is this? Any one of you? This is pneumoperitoneum. Now, do you understand that when you are in a CT scan, you are lying down? So air rises up. If you have free air, it rises up and it collects below the anterior abdominal wall. Are you clear? So this entire black thing that you see below the anterior abdominal wall is pneumoperitoneum. Okay. This is IVC beta. Okay, this is a little bit of the duodenum which is visible to you. Don't worry about that. Just forget about it. Not important. This is superior mesenteric artery, superior mesenteric vein. Okay, let me make it colored so that you aorta, inferior vena cava. Okay, clear? Okay, and okay, very good. So you might have studied in surgery that ये जो in surgery में आपने पढ़ा होगा बेटा, ये aorta है, ये superior mesenteric artery. अगर किसी की superior mesenteric artery acute हो, if your superior mesenteric artery is more acute, what will happen? It will compress the left renal vein, and that is called as the nutcracker syndrome. You might have studied this in surgery, a nutcracker syndrome. Left renal vein, if it is compressed between the aorta and the superior mesenteric artery, that is called as nutcracker syndrome. Yes, very good beta. So it is such a pleasure to teach all of you intelligent students. You have a lot of knowledge. All I need to do is polish it up. Everybody understands this? Yes, very good. Okay, now see, let's see if you are able to understand one more CT image. Okay, I told you now I will also show you CT scan of the abdomen today, because in my previous classes we have seen CT of the chest, CT of the brain, MRIs. Now we'll look at CT abdomen. This is your liver. What structure is this? This is a gallbladder. What is this? This is your normal spleen. This is your left kidney, aorta, IVC. Everybody clear? Clear? Okay. Now please see, from your aorta, an artery arises from the ventral part of the aorta. An artery goes like this and divides into common hepatic and the splenic artery. That is your, anybody? That is your celiac trunk. Remember the celiac artery? Have you read about this? That the ventral branch from aorta, what you see here is the celiac trunk, which divides into the common hepatic and the splenic artery. Anterior to that, you can see this area is your pancreas. You can see the tail of the pancreas in relationship to the splenic hilum. You have the tail of the pancreas, and then you see the pancreatic body. Okay. My question is, beta ji, if any of you can answer beta, okay. Can you see the head of pancreas here? Can you see the head of pancreas? No. Pancreas is like this. The tail is higher up, the head is lower down. So you cannot see the entire pancreas in one section. Pura pancreas एक section में नहीं दिखेगा. If I can see the tail, you will not be able to see the head. अगर head दिखेगा तो tail नहीं दिखेगा. Everybody clear? Very good. Very good, Betaji. All of you are able to answer. Very good. So that means you studied your anatomy, you studied your surgery very well. Now tell me, behind the inferior vena cava, anterior to the left kidney, can you see this V or Y-shaped structures? What are these? These are your adrenals. These are your adrenal glands. Can you see suprarenal glands? These are your suprarenal glands. Okay. So Sahil Kumar is asking, what is nutcracker syndrome? Nutcracker syndrome is compression of left renal vein between aorta and superior mesenteric artery is called as nutcracker syndrome. Everybody understands? Okay, very good, very good. These are your adrenals. So this is a normal CT abdomen. Okay, so we have seen a normal CT abdomen. Now I will ask you aorta and superior mesenteric artery, beta. ध्वनि जोशी, superior mesenteric artery और aorta के बीच में compression होगा. Okay, very good, beta. Okay, now let's see if you can answer, beta. No, I've shown you normal. Let's see abnormal now. This is an image that has been asked in the AIMS exam from our workbook in the past. This is liver. This is your gallbladder. ठीक है बेटा. Right kidney, left kidney, aorta, inferior vena cava. This small black thing and white thing is your stomach. Why we are able to see stomach like this? Remember, in CT abdomen, we give both oral and IV contrast. CT abdomen करते हुए हम IV contrast देते हैं इंट्रावीनस, जो कि ब्लड वेसल में दिख रहा है. We also give the patient oral contrast, which is seen in the bowel loops. Okay. Now any one of you can answer. Where is the abnormality in this picture? Okay. बेटा उसमें राइट किडनी क्यों नहीं दिख रही थी पहले वाले में? बेटा जी, आई थॉट आप नहीं पूछोगे पूजा, बट आप पूछ रहे हो. बेटा दोनों किडनी एक लेवल पे नहीं होती ना पूजा. रिमेंबर, लेफ्ट किडनी इज हायर, राइट इज लोअर. So if you take a section, first you will see left kidney, then you will see both the kidneys together. Do you agree? Okay, now let's see now. Okay, enough of the basics. Now we go to the disease. Now please see with me, beta. I'm sure you can answer. Beta ji dekhiye aur bataएं. Can you see and tell me what organ do you think is this and what is the abnormality in this organ? What organ is this? This is pancreas. What has happened to the pancreas? The entire pancreas appears large and swollen. Swollen देखा तो we remember edema. Edema देखा तो हमें क्या याद आ गया? Capillary leak होना. Capillary leak होना मतलब inflammation. So I can say probably we are looking at acute pancreatitis. समझ आया? Pancreatitis मतलब pancreas की inflammation. Acute pancreatitis. Pancreas is swollen and edematous, so we think of inflammation, we think of pancreatitis. Are you clear? Now let's understand it further. Now please try to imagine with me, otherwise this part you will miss, and this is very important to understand, beta. Please see. Okay, very important. Look at the pancreas parenchyma that I am marking, and look at this area that I am marking with a star. Okay, any one of you can look at it and tell me what is the difference. The star marked area is totally dark. It is not taking up any dye. It is appearing non-enhancing. Can you think of a reason why? भाई नॉर्मल पैरेंकाइमा तो ऐसा होना चाहिए था. ये कैसा है? Non-enhancing. It is not taking up any dye. The blood vessels are taking up dyes. Okay, any one of you? Why is the part of pancreas non-enhancing? So the non-enhancing part, why something would not take up the dye is if it is dead is the necrosis. Non-enhancing part is the necrosis. Are you clear with this or not? गरिमा बेटा फिर कंफ्यूज हो रहा है बेटा, जब दो किडनी एक लेवल पे नहीं है बेटा, कैसे मैं समझाऊं ना बेटा, देखो देख ऐसे है, देख है ना, ऐसे है, ठीक है। जब इसका ये वाला पार्ट था, इसका ये वाला पार्ट है, अंडरस्टैंड, वो किडनीज आर नॉट सिमेट्रिकल, दे आर नॉट, मतलब वो एक साथ नहीं है, एक थोड़ी ऊपर एक थोड़ी नीचे है, इसलिए ऐसा लग रहा है आपको, है ना। ओके बेटा, दैट इज नॉट एबनॉर्मेलिटी, फिर पेपर में सब गलत हो जाएगा, है ना। So this non-enhancing part is nothing but necrosis. So you might have studied in surgery, in acute pancreatitis, the diagnosis is made if you have any two of these three. Remember, severe epigastric pain, amylase like elevation, and CT or MRI suggestive of pancreatitis. Okay, cross-sectional imaging suggestive of pancreatitis, radiological evidence of pancreatitis. Okay, any two is enough to make a diagnosis. So acute pancreatitis is diagnosed by any two of them: epigastric pain, serum amylase lipase levels, and radiological evidence. Any two is enough to make a diagnosis. So now see how in AIMS people, they will ask you a question. Let's see if you can answer. CCT is essential to diagnose acute pancreatitis. What do you think, children? CCT is essential to diagnose acute pancreatitis. The answer is false. It is not necessary. Any two is important. हो सकता है लाइपेज बड़ा हो और पेशेंट के पेन हो, it is enough. You don't need a CT scan to diagnose it. Everybody understands? Everybody understands? Okay. Now, so CT is not essential for diagnosis. The role of CT is to comment on severity of acute pancreatitis. The role of CT is to comment on severity of acute pancreatitis. Everybody understands? It should be done 72 hours after the presentation. Immediately नहीं करना CT, 72 hours के बाद करना है for presentation. Once the diagnosis is clear, if you are able to make a diagnosis, then CT is required to be done for severity after 72 hours. Okay. How do we know severity is? Pathologically, you can divide pancreatitis into two types: edematous, necrotizing. Okay, the mild form is the edematous form, which you see in people with gallstones. Necrotizing form is the severe form, which is commonly seen in alcoholics. Okay, and this is the pathological terminology that we use. And on CT we do something called as CT. Okay, we use in CT something called as modified CT severity index, which is based on three things: amount of inflammation, degree of necrosis, presence of extra pancreatic complications. Okay, CT should be done after 72 hours, not within, because initially if you are able to make diagnosis, you don't need a CT scan then, because it is not essential for diagnosis. Clear? A lot of students, MBBS students, get it wrong in the exam. So this is not Balthazar grading. वो Balthazar नहीं है. आजकल जो हम यूज करते हैं उसका नाम है modified CT severity index, which is based on three parameters: amount of inflammation, degree of necrosis, presence of extra pancreatic complications. Okay, please remember this is a potential question for your exams. Are you able to understand now? So now look at the image again and tell me, is this edematous pancreatitis or is this necrotizing pancreatitis? क्या लगता है बेटा, किस तरह का pancreatitis है ये? This is necrotizing pancreatitis because we saw non-enhancing areas in the pancreatic parenchyma, which was telling us that this is necrotizing pancreatitis. Okay, everybody understands? Okay, now second question now. Anybody now look at the image and answer? Liver, gallbladder, right kidney, left kidney, aorta, inferior vena cava, portal vein, colon. Okay, any one of you now, you can see the transverse colon that I have marked. You can see the portal vein behind the neck of the pancreas. You can see inferior vena cava, aorta, kidneys, and the liver. Okay, where is the problem? The disease again is in pancreas. In the CT scan, you can see there is a disease in the pancreas. Pancreas कैसा है बेटा? swollen है कि shrunken है? Pancreas is shrunken, है ना? Pancreas shrunk हो गया तो because of must be fibrosis. Fibrosis happens in chronic inflammation, and not only beta ji, please see, not only is the pancreas shrunken, it is also calcified. And we know by now calcification is seen in chronic diseases, chronic disease. So we are dealing with chronic pancreatitis. Okay, so are you able to understand how I am able to understood? I am able to give you the diagnosis so far. Okay, so radiologically, the investigation that we do in pancreatitis is CCT, but it is not essential for diagnosis. It is required for severity, should be done for severity after 72 hours if the diagnosis is clear. Okay, very good, beta. Now, two questions. Investigation of choice for chronic pancreatitis. Investigation of choice for chronic pancreatitis is, anyone, is MRCP with secretin. Investigation of choice for chronic pancreatitis is MRCP with secretin, where you will see pancreatic duct will have narrowing dilatation, narrowing dilatation, narrowing dilatation, narrowing dilatation. What is this called as? Chain of Lake's appearance of pancreatic duct. Clear? Clear? Investigation of choice for chronic pancreatitis is MRCP. Second question. Best investigation for chronic pancreatitis is EUS. Today, the best investigation to diagnose chronic pancreatitis is a endoscopic ultrasound. Best investigation for chronic pancreatitis, endoscopic ultrasound. Clear? Now you can see again in front of you on this page, we had three images. Okay. First image was normal. Second is acute pancreatitis. Third is chronic pancreatitis. Okay. Now we will write some rare things here. Can you have autoimmune pancreatitis? Yes. Autoimmune pancreatitis is now known to be IgG4 related disease. Only one word to remember in radiology is sausage shaped pancreas. Okay, just remember this one line. Okay, just one line. Sausage shaped pancreas is seen in autoimmune pancreatitis. Can you recall one more disease I told you in my last class, which was IgG4 related? That was retroperitoneal fibrosis. Autoimmune pancreatitis is also IgG4 related disease. One more to remember. Pancreatitis can also be associated with a duct ductal abnormality called as pancreatic divisum. It is a embryological abnormality of the pancreatic ductal system. Investigation of choice for pancreatic divisum is also MRCP. Okay, clear? Everybody understands? Now, some of you are asking, sir, chain of legs क्यों हुआ? बेटा जब फाइब्रोसिस होगा, जब डक्ट में फाइब्रोसिस होगा, जहां जहां फाइब्रोसिस होगा, बेटा जी डक्ट में नैरोइंग होगी, उसको कहते हैं स्ट्रिक्चर. जहां नैरोइंग होगी उसके प्रॉक्सिमल डायलेटेशन होगी. सो नैरोइंग इज द स्ट्रक्चर्स. स्ट्रिक्चर मतलब नैरोइंग इज द फाइब्रोसिस इन द पैंक्रियाटिक डक्ट and then the dilatation is the proximal part. Everybody understands the concept? Okay, so far we've seen pancreatitis. Just one more image to go that will formulate the radiology of pancreas for you. This is your liver. This is your right branch of portal vein, aorta, spleen, stomach. Okay, and there is a disease here. Any one of you tell me the disease that you are able to see here, is it as black as the air in the stomach? No, it is not as black as the air in the stomach. As white as the calcium? No, it is fluid. The color is that of fluid. There is a there is a wall around it. There is a well-walled off fluid collection behind the stomach. Behind the stomach, you have an area of the peritoneum, which is called as the lesser sac. So you can see there is a well-walled off fluid collection in the lesser sac. We will call it pseudocyst. We will call it pseudocyst. Are you clear? Pancreatic pseudocyst. Just one clarification on the terminology. If you understand this terminology, then you will never get it wrong. This is now a time to learn one classification called as Atlanta nomenclature, given in Atlanta. It says if there is a fluid collection in a patient with acute edematous pancreatitis more than 4 weeks after, more than equal to 4 weeks later on, is called as pseudocyst. So what is pancreatic pseudocyst? Pancreatic pseudocyst is a well-defined, a well-walled off fluid collection seen after an episode of edematous pancreatitis after 4 weeks. But the Atlanta nomenclature says if you have a well-walled off fluid collection after an episode of acute necrotizing pancreatitis after 4 weeks, then you will call it as walled off necrosis. Then you use a word walled off necrosis. Are you clear? Are you able to understand this? So now pseudocyst आपने केवल edematous pancreatitis के सीक्वल में बोलना है. नेक्रोटाइजिंग के बाद pseudocyst नहीं होता. Everybody understands? Okay. Are you able to understand the terminology? Yes, Nikita, very good. You have answered it very well. And this is very important. This will ask in the coming AIMS exam. It is given in Barrium love, but many people will miss the understanding part. है ना? ये नया terminology है, याद कर लो. This is how you describe pseudocysts. Very good, beta. Now one more question. Okay, one more question for you. Then I will show you some. Okay, one more question, है ना? Let's see if you can answer. Okay, let's see if you can answer, beta. Any one of you. A middle-aged female has a unicystic lesion in the pancreas, no history of trauma, no pancreatitis, no gallstone. What should you suspect? Okay, let's see, any of you can answer this concept. Any of you has studied pathology properly can answer this question to me. A middle-aged female has a unicystic lesion in the pancreas with no history of trauma, no pancreatitis, no gallstone, that is trying to rule out. We are trying to rule out. बोलो, pancreatitis नहीं हुआ है तो pseudocyst नहीं है ये, फिर क्या हो सकता है? This is where you think of mucinous cystic neoplasm of the pancreas. पैंक्रियाज में सिस्ट बिनाइन भी हो सकते हैं लेकिन सिस्टिक नियोप्लाज्म भी हो सकते हैं. Cystic neoplasms are more common in the female gender. Okay, mucinous are unicystic or oligocystic cystic masses, and the history will try to rule out pancreatitis. ठीक है, सेकेंड क्वेश्चन है बेटा आपके लिए. Old lady has a multicystic mass in the pancreas with a central stellate calcific sunburst scar. What will you mark as the answer? बताओ बताओ बताओ. म्यूसिनस का उल्टा क्या होता था? सीरस. So then the answer is a benign cystadenoma of the pancreas. सीरस cystadenoma of the pancreas. आप समझ आया? सीरस वाला ज्यादा ओल्डर एज ग्रुप फीमेल में दिखेगा, मल्टीसिस्टिक होगा, सेंटर में स्कार होगा. ओके, एंड सीरस सिस्टेडेनोमास आर बिनाइन. कुछ नहीं करना यहां पे, बिनाइन है. एवरीबडी अंडरस्टैंड्स? आर यू क्लियर? ऑलिगो मतलब कम सिस्ट होंगे. ओके, एवरीबडी अंडरस्टैंड्स अ डिफरेंशियल डायग्नोसिस ऑफ हाउ टू अप्रोच इन द क्वेश्चन. ओके, वन मोर क्वेश्चन बेटा फॉर यू बिकॉज यू आर आंसरिंग सो मच. ओके, male equal to female, multicystic lesion in the pancreas which is communicating with the pancreatic duct. आप क्या सोचोगे बेटा? Serous cystadenoma does not communicate with the pancreatic duct. आप क्या सोचें? मेल में भी हो सकता है, फीमेल में भी हो सकता है. ऐसा ट्यूमर बताओ जो मल्टीसिस्टिक होगा बट इट कम्युनिकेट्स विद द डक्ट. दैट इज IPMN, इंट्राडक्टल पेपिलरी म्यूसिनस neoplasm malignancy of the pancreas. IPMN. Concept बना? Okay, so the key here is to understand how to think, not what to think. So what I have given you an idea on, okay, whenever I see a cystic lesion, how do I think? That we have to look at the history and we have to correlate. Am I looking at pseudocyst? Is this walled off necrosis? Is this a cystic neoplasm? Female hai ke male hai? And now we have to look at all those things in the question. Okay, now we come to liver. In liver, okay, we will look at a very, very important tumor in liver, which you all need to know today because it is seen in more commonly in male, has bad prognosis. It is called as hepatocellular carcinoma. सुना है किसी ने पहले HCC? Hepatocellular carcinoma, bad prognosis malignancy, more common in males. Okay, now any one of you can answer this question to me. Hepatocellular cancer के बारे में जल्दी से बताना है. इन्वेस्टिगेशन ऑफ चॉइस क्या है और स्क्रीनिंग इन्वेस्टिगेशन कौन सी करेंगे? स्क्रीनिंग किन लोगों में करेंगे? सिरहोसिस के पेशेंट्स में. ओके, सो इन पेशेंट्स विद सिरहोसिस यू डू स्क्रीनिंग अल्ट्रासाउंड्स एवरी 6 months. जिन लोगों को सिरहोसिस होता है उनका हर 6 महीने अल्ट्रासाउंड करते हैं टू स्क्रीन फॉर HCC. But if I'm suspecting HCC, investigation of choice is a triple phase CT. Investigation of choice for a hepatocellular cancer is a triple phase CT. But please note it down with carefully. अगर स्क्रीनिंग पूछा तो अल्ट्रासाउंड मार्क करना है. ओके, AFB नहीं है आंसर वहां पे बेटा. ओके, everybody understands AFB नहीं है. Okay, now once you're clear, let's see if you can answer beta. I'll give you a question. Okay, now what is a triple phase CT and why do we need it? Triple phase CT means that you give IV injection of dye, rapid IV injection of dye. After 25 to 35 seconds, we do a CT of the abdomen, which is called as hepatic, लिख लो बेटा, arterial phase. Then we do a CT at 60 to 70 seconds, which is called as portal venous phase. Then we again repeat a CT at 5 to 10 minutes, which is called as equilibrium phase. Okay. Now name three phases of triple phase CT: hepatic arterial phase, portal venous phase, equilibrium phase. अभी मैं इसको लिख रहा हूं HAP, इसको लिख रहा हूं PVP. इजी, आगे के लिए आसान लिखने के लिए. Everybody, should I repeat? Should I repeat, beta? Okay. So there, what are three phases of triple phase CT? Hepatic arterial phase, portal venous phase, equilibrium phase. Now, why do we need this is try and understand what is the blood supply of liver. Blood supply of liver is dual. Liver is an organ which has dual blood supply. कैसे आती है blood supply बताओ? पोर्टल वेन से भी आती है और हेपेटिक आर्टरी से भी आती है. मेनली किससे आती है? मेन सोर्स ऑफ ब्लड सप्लाई टू द लिवर इज पोर्टल वेन. मेन सोर्स ऑफ ब्लड सप्लाई टू द लिवर इज पोर्टल वेन. बट मेन सोर्स ऑफ ब्लड सप्लाई टू लिवर ट्यूमर्स like hepatocellular cancer, like liver metastasis, is hepatic artery. Are you able to understand the concept? बहुत जरूरी है, नहीं तो नहीं समझ आएगा. एक बार why समझ लेते हैं, it will make it easy. Normal liver is mainly supplied by portal vein. Liver tumors like hepatocellular cancer, metastasis are mainly supplied by hepatic artery. But there is a difference. Hepatocellular cancer is a hypervascular tumor, बहुत high vascularity का tumor है, supplied by hepatic artery. While metastases are usually hypovascular. Okay, hypovascular. Okay, any one of you? Liver metastases are typically coming from colorectal malignancies. ठीक है, colonic और rectal malignancies से liver में metastases आते हैं. These are usually hypovascular. HCC is hypervascular. और triple phase CT के phases क्या थे? Hepatic arterial phase, portal venous phase, equilibrium phase. Now, can I ask you a question before teaching you radiology? Hepatocellular cancer will be best seen in hepatocellular cancer कौन से फेज में दिखेगा आपको? आर्टीरियल फेज में कि वीनस में? बोलो. Yes, Himapriya, very good. Tell me. Hepatocellular cancer is mostly seen in the arterial phase. Arterial phase. क्यों? क्योंकि hypervascular tumor है और hepatic artery से सप्लाई होता है. Liver metastasis, despite being supplied by hepatic artery, they are hypovascular and they are usually not seen in the arterial phase. ये arterial phase में नहीं, venous phase में दिखेंगे. I will show you why. I will show you. Okay. Now we will come back to the concept with an image. This is how a triple phase CT would look like. This is how a triple phase CT will look like. Please see with me the anatomy. This is your liver. This is your spleen. stomach, aorta. Okay, can you see the anatomy? Very good. Now I want to show you something which is subtle. थोड़ा मुश्किल है देखने में, but if you spend time दिखेगा. मैंने पहले भी सिखाया था, देखने के लिए टाइम डालना पड़ेगा, क्रिटिकल थिंकिंग करनी पड़ेगी. इफ यू जज थिंग्स यू विल ऑलवेज गेट देम रॉन्ग. जजमेंटलिज्म में कुछ नहीं कर पाएंगे, हमेशा गलत करोगे. जज करते रहोगे बैठ के, गलत होता रहेगा, है ना. सो वो आदत पड़ जाती है ना इंस्टाग्राम में बैठ के जज करने वाली, वो नहीं करना हमने, है ना. वी हैव टू डू क्रिटिकल थिंकिंग. So when you do critical thinking, we see the surface of this liver. What do you think? थोड़ा सा सच को exaggerate कर रहा हूं कि आप देख पाए. Can you see now? The surface of this liver is nodular. The surface of this liver is appearing nodular. Why? कौन सी ऐसी बीमारी पड़ी जहां लिवर का surface nodular था? That was cirrhosis. This patient has cirrhosis. Okay. Now, can you see any tumor on the plane? This is a non-contrast CT scan. Can you see any tumor in it? No, because the tumor is also made up of liver cells. It is hepatocellular cancer. So there is no attenuation difference between the tumor and the normal liver parenchyma. यानी बिना डाई दिए आप ट्यूमर और लिवर पैरेंकाइमा में फर्क नहीं कर सकते, क्योंकि दोनों ही लिवर के सेल के बने. I will repeat in English. We cannot differentiate between HCC and the liver parenchyma on a non-contrast CT because both of them are made up of same tissue. Okay. Now, when we give the dye after 25 to 35 seconds, I have given the dye. You can see that the dye has reached the aorta. The aorta is appearing very bright, but it has not reached the vein. दिख रहा है? डाई 25 सेकंड के बाद aorta में आ गई है, वेन तक नहीं पहुंची है. So that means this must be the arterial phase. In the arterial phase, can you see a enhancing heterogeneous enhancing nodule? Can you see? So there is a nodule showing enhancement in the hepatic arterial phase. Okay, are you clear? HCC is best seen in hepatic arterial phase because it is a hypervascular tumor supplied by hepatic artery. बच्चे सुने, दोबारा ध्वनि बेटा सुनिए कि जब आपके आर्टरी में डाई है, आर्टरी में, तो वो ट्यूमर को मिलेगी, लिवर को नहीं मिलेगी. लिवर को तो पोर्टल वेन मेनली सप्लाई करती है. यू अंडरस्टैंड द लॉजिक बिहाइंड इट? थोड़ा मुश्किल है, समझना है. फिर देखो, नाउ व्हेन वी रिपीट द सीटी आफ्टर 60 to 70 seconds, there is some dye in the aorta, but now the portal vein is also visible because we are at the venous phase. Venous phase में the liver will enhance. Okay, venous phase में the dye is in the portal vein. Portal vein will give the dye to the liver parenchyma. The liver parenchyma will take up the dye. But the tumor will now is only getting dye in the arterial phase. In the venous phase, the tumor is showing washout. The tumor is washing out. So we cannot appreciate the tumor any longer. Liver ज्यादा डाई का अपटेक कर रहा है, ट्यूमर लॉस कर रहा है. They have become isodense. दिख ही नहीं रहा हमें. This is called as washout. So remember, portal venous phase में the normal liver parenchyma enhances, but the HCC will demonstrate loss of dye, which is called as washout. Okay, everybody understands? Okay, just give me 1 second, and then I will show you the equilibrium phase after this. Just give me 1 second. Okay, I'm just getting it back. Just give me 1 second. Till the time you can take in some breaths and enjoy your time. Okay, I'm just restarting it. Give me just 1 second. Okay, so this is where we were. Actually, all these computers were made by Western people and they had no idea how long we have to work in India. So they have no idea about all this. All the Western people, when they teach, we have British people also, they come to India for our DAMS MRCP classes, and I see them, they get tired after half an hour. They said, आधा घंटा हो गया, बहुत पढ़ा दिया. मैंने कहा अभी तो शुरू हुआ है बेटा. You understand, kidding? So all these people, they all this Microsoft and all, they don't know that we have to work for long hours. So now what happens is, after 5 to 10 minutes, when you do a CT again in the equilibrium phase, only the capsule, only the periphery of the tumor will retain some dye. Central part will not retain the dye. Only the capsule will retain some dye. बाकी सब जगह से नॉर्मल लिवर से भी ट्यूमर से भी डाई वॉश आउट होता जाएगा. ओनली द कैप्सूल विल रिटेन द डाई. Okay. Now let's see if you can answer beta. Let's see if you can answer beta. Any one of you. Hepatocellular cancer on triple phase CT shows. It shows enhancement in the hepatic arterial phase. Washout in the portal venous phase. Capsular enhancement in the equilibrium phase. याद करना है, सिर्फ ये 3 लाइन है. कारण मैंने आपको पहले ही बता दिया. दिस इज हाउ यू डिस्क्राइब HCC ऑन अ CT स्कैन. Okay. Okay. And this chat box is, the chat box is actually very interesting sometimes. Okay. Now see, this is what is called as Lyrad's criteria. Lyrad's क्या होता है? HCC को, how to diagnose HCC on a CT scan? We use a criteria called as Lyrad's, liver imaging, reporting and data system. Lyrad's क्या होता है? Liver imaging, reporting and data system. Just 4 lines to remember. Not for pediatric tumors. Only use Lyrad's criteria if the patient is clinically high risk for HCC. Okay. Only use, listen to me, only use, remember, only use Lyrad's criteria if the patient is clinically high risk for HCC. कौन होता है high risk for HCC? जिनको cirrhosis है या chronic hepatitis B virus infection है, वो लोग. Okay. Number 3, if you see Lyrad's criteria क्या होते हैं? Hepatic arterial phase enhancement, demonstration of washout, okay, capsule demonstration in the equilibrium phase, more than equal to 50% growth in less than equal to 6 months. These are major criteria to call a liver nodule as hepatocellular cancer. किसी भी लिवर, सुनो मेरे साथ, बायरार्ड्स बाद में बताऊंगा, पहले ध्यान से देखो. किसी भी लिवर के नोड्यूल को HCC कब बोलेंगे? अगर आर्टीरियल फेज में एनहांस हो रहा हो, पोर्टल वीनस फेज में वॉश आउट हो, कैप्सूल दिखे, और तब भी ना समझ आए तो 6 महीने बाद दोबारा देख लो. अगर 6 महीने से कम में 50% से ज्यादा ग्रोथ होगी तो भी वो हेपेटोसेलुलर कैंसर है. Okay. Equilibrium phase में I said, Devna, I said capsule दिखेगा. Capsule is seen in the equilibrium phase. Okay. Anyone now? Okay. Now look at this next picture with me. This is your liver. This is your spleen, aorta, IVC, right branch of portal vein, left branch of portal vein. Now look at this image and tell me, do you see the dye in the vein? Yes, dye has reached the portal vein. Dye portal vein तक पहुंच चुकी है. Do you agree? That means it is portal venous phase. Now look at the disease. एक है कि disease multiple है. Multiple disease दिख रहे हैं. एक लोब में कि both lobes में? Both lobes में दिख रही है multiple disease. That means we are looking at a hematogenous problem. है ना? जो प्रॉब्लम दिख रही है उसको ब्लड सप्लाई पोर्टल वेन से मिल रही है कि नहीं मिल रही है? उसको पोर्टल वेन इज नॉट सप्लाइंग. लिवर पैरेंकाइमा इज अपीयरिंग वाइट, is taking up the dye, but the disease is not taking up the dye because it is not supplied by portal vein. What is this? This is metastasis. So liver metastasis will typically be seen multifocal, bilateral, okay, and it is not supplied by portal veins. So in the portal venous phase, they will appear hypodense. तो dark दिखेंगे आपको थोड़े. Okay, everybody understands? Okay, very good. Because most of the metastases are hypovascular, like colorectal cancer metastasis are hypovascular. Just remember an exception. Carcinoid tumor causes hypervascular metastasis to the liver. ठीक है, ज्यादातर मेटास्टेसिस हाइपोवैस्कुलर होते हैं, लेकिन कार्सिनॉइड हाइपरवैस्कुलर होगा. ओके, और कैप्सूल में फाइब्रस टिश्यू होता है पारस, सो दैट इज व्हाट इज रिटेनिंग द डाई. ओके ओके, नाउ लेट्स गो फर्दर. ओके, अब थोड़ा सा इमेजेस और हैं, लेट्स सी देम एंड लेट्स सी, डोंट ट्राई टू अंडरस्टैंड. लेट्स सी, लुक एट दिस बेरियम इमेज, है ना, ये बेरियम मील फॉलो थ्रू है बेटा. जस्ट लुक एट दिस बेरियम मील फॉलो थ्रू एंड टेल मी where is the disease. This is the part which is having a disease. ठीक है, ये पार्ट में बीमारी है, आपने बताना है. ओके, आप लोगों ने बताना है ये पार्ट क्या है. ओके, लेट मी लेबल इट फॉर यू. दिस इज योर डिसेंडिंग कोलन, transverse colon, this must be your cecum, and this must be your terminal ileum. Okay, what do you see in this image? The cecum appears conical and contracted. Ileum is also fibrous and has a narrowing. I will say ileum also has a stricture. And ileum, if I look at this, the cecum is not at its normal position. Normal position should have been lower down. The cecum is appearing pulled up. Okay, anybody? Now see, अब सोच के बताना बेटा, ऐसी कौन सी बीमारी होगी जिसमें cecum भी contracted है, ileum भी contracted है. So why would anything be contracted? If a part of the body is contracted, we think of fibrosis. If we see fibrosis, we think of chronic inflammation. So what chronic inflammatory disease is typically involving ileocecal junction? That is ileocecal cox or tuberculosis, bowel TB. Everybody understands how to think? So this is a barium image showing you bowel tuberculosis. But only one update I wanted you to remember. Investigation of choice for bowel tuberculosis now is CT enterography. It is not barium any longer. Now for bowel TB, we prefer CT scan से bowel को देखना, CT enterography. Everybody gets it? Remember, investigation of choice for bowel tuberculosis is CT enterography. Okay, everybody? अच्छा ठीक है, आगे देखते हैं बेटा. बेरियम एनीमा के अंदर ना, मैंने बताया था ना, स्मॉल बावल में अंदर बेरियम ज्यादातर नहीं दिखेगा. लेट्स ट्राई टू अंडरस्टैंड. आई विल गिव यू मोर आइडियाज बेटा, प्लीज वेट, है ना. ओके रॉकी, ओके बेटा रॉकी. ओके, आई होप यू हैव, दिस इज योर राइट नेम, है. ओके, now see beta Rocky, huh? Everybody, now this next image is a barium enema. Okay, and it is written in the question that this is barium enema. Just look at this barium enema and tell me, this is your rectum, this is your descending colon, transverse colon. Any one of you can tell me the part of the colon that we are able to see, rectum, descending colon, transverse colon, क्या हुआ उसमें? They are narrow. There is fibrosis, there is contraction, there is fibrosis of the entire colon, and there is so much fibrosis that the colonic loop has no haustral. So that means we must be dealing with a chronic inflammatory disease which is involving rectum onwards, entire colon, like a lead pipe. What could this chronic inflammatory disease be? Anybody? This is ulcerative colitis. This is ulcerative colitis. Okay. So happy birthday, everybody. Happy birthday, Rocky. Happy birthday, Matilda. Okay. Anybody else also has a happy birthday, please let me know. So this is how you remember lead pipe colon ulcerative colitis. Okay. Are you able to understand कि दोनों में chronic inflammatory changes हैं. TB में वो ileocecal है सिर्फ, जबकि ulcerative colitis में it is rectum onwards involving the entire colon. You remember this or not? Did you study this in pathology and surgery also and medicine also? Ulcerative colitis is a mucosal disorder, usually involves the bowel in a contiguous fashion. Remember this mucosal contiguous fashion? Yes, happy birthday Varun as well. Okay, Sri Lakshmi also happy birthday. Okay, because of all these birthdays, do send me cakes as well. And rectum is almost always involved in the ulcerative colitis. So it begins in rectum. Okay, let's see the next picture. A patient with, okay, before we see the next picture, what is the earliest Barrium sign of ulcerative colitis? The answer is mucosal granularity. Earliest Barrium sign of ulcerative colitis is mucosal. Happy birthday, Hina Kausar as well. Sneha as well. I think so many birthdays. Parth, Digvijay Singh. Okay. Abhishek. Oh, today is like a birthday day. It's like too many birthdays today. Sagar as well. Happy birthday. Okay. So this is a patient with ulcerative colitis. What do you see in this X-ray? This is a previous AIMS visual from this workbook. Please see if you can answer. This is an X-ray abdomen in a patient with ulcerative colitis. What do you suspect? A patient with inflammatory bowel disease. What are you able to see? You can see the transverse colon. This is the transverse colon, the entire thing that I'm trying to show you. The transverse colon is dilated. The transverse colon is dilated more than 6 centimeter and is ahostral. If in a patient with ulcerative colitis you see dilatation of the colon, when a patient who comes to emergency with acute abdomen, think of toxic megacolon. That is when you think of toxic megacolon. Are you clear? Okay, are you clear? Beta, some things you have to do together. Okay, just wait. After ulcerative colitis, without Crohn's disease, घर नहीं जा सकेंगे बेटा. Crohn's देखना पड़ेगा अभी, है ना? Crohn's के बिना घर चले गए तो फिर बाद में बहुत मुश्किल हो जाएगा. Ulcerative colitis, Crohn's disease, भाई भाई हैं बेटा, उनके साथ रहना पड़ेगा हमें. Okay, Crohn's disease. Crohn's disease, remember, can involve any part of the bowel. Involvement can be skipped. Involvement is transmural. Okay, remember this or not? It has, okay, ulcerative colitis, Crohn's disease, साथ में करने. Crohn's disease has mesenteric border predominance in its involvement. It is associated with perianal fistulas. कभी भी पूछें कौन सी इन्फ्लामेटरी बाउल डिजीज में मेसेंट्रिक बॉर्डर ज्यादा इन्वॉल्व होता है या पेरिएनल फिस्टुला ज्यादा होते हैं, दैट इज क्रॉन्स डिजीज. Okay, that is Crohn's disease. Now, how do we identify Crohn's disease on a CT scan is, just to give you an idea, suppose this is your bowel loop. This is your bowel loop. This entire thing is your mesentery. This is your mesentery. Okay. In mesentery, in the normal mesentery, you should have dark appearance because of the presence of fat in the mesentery. The mesentery, the normal mesentery should be dark because of presence of fat. This is normal appearance. Okay. But if there is inflammation, we already know from our discussion so far, inflammation leads to hyperemia. So increased number of vessels will be seen here. This is called as, if you have inflammation in the fat, we will use a word fat stranding. Just give me 1 second. We will use a word fat stranding in the mesentery, or we will use a word comb sign. It looks like a hair comb. So are you clear with this or not? That Crohn's disease, because it is having inflammation at the mesenteric border, because of inflammation, you will have increased number of vessels. These blood vessels will be looking like strands, like lines. So we'll call it comb sign. Are you clear? So comb sign on CT is seen in, what will you mark? Crohn's disease. Crohn's disease can also affect your stomach. So if there is stomach or gastric Crohn's, then stomach appears conical like this. So this conical narrowing of the antrum that you see in Crohn's disease is called as ram's horn stomach. Okay. So the key words to remember for Crohn's disease are: any part of the bowel can be involved, involvement can be skipped, it is transmural, mesenteric border is predominantly involved, perianal fistulas are there, and in chronic stage, the bowel which is involved with inflammation will become narrow, so you will develop strictures, which is called as string sign of Cantor. In which disease do you see string sign of Cantor? Crohn's disease. So in this page, actually speaking, I just discussed with you some common inflammatory bowel diseases like TB, ulcerative colitis, and Crohn's disease. Now we'll quickly look at some miscellaneous images, just miscellaneous. You have already seen this in ENT, don't worry, just tell me, what is this? Swollen epiglottis. What is this called as? Thumb sign or thumbprint sign on neck X-ray. Seen in? Anybody? Did you read this so far? Thumb sign, thumbprint sign on neck X-ray seen in? Acute epiglottitis. This is acute epiglottitis. Okay, very good. But in the exam, the question is like this: thumbprinting in splenic flexure of colon is seen in. Okay, now can you answer? Thumbprinting in splenic flexure of colon is seen in. अब कई बच्चे यहाँ पे भी एपिग्लोटाइटिस मार्क करके आ जाएंगे, कहेंगे नहीं सर ईएनटी वाले सर ने बताया यही मार्क करना है. वो ये नहीं देखेंगे कि एपिग्लोटिस नेक में होता है, कोलन में नहीं होता. दिस इज नॉट द आंसर. देन वी नीड टू मार्क इश्केमिक कोलाइटिस. And you might have read this in surgery that splenic flexure is a watershed area between the superior and the inferior mesenteric artery territory. Splenic flexure से पहले superior mesenteric artery supply करती है, distal to it inferior mesenteric artery, and that is why this is the area where you develop ischemia. So ischemic colitis shows thumbprinting appearance. Okay. Sawtooth appearance in colon. Sawtooth appearance in colon is seen in diverticulosis. Okay. Clear? Acute diverticulitis can come to you as acute abdomen with left-sided pain. Investigation of choice remains CCT. एक्यूट एब्डोमेन में ज्यादातर हम कॉन्ट्रास्ट सीटी करते हैं, चाहे अपेंडिसाइटिस सोच रहे हो चाहे डायवर्टिकुलाइटिस सोचेंगे. द आंसर रिमेन्स कॉन्ट्रास्ट एनहांस सीटी. राइट साइड पे पेन होता है, वी थिंक ऑफ अपेंडिसाइटिस. लेफ्ट साइड पे एक्यूट पेन है, वी थिंक ऑफ डायवर्टिकुलाइटिस. दोनों में ही आंसर कॉन्ट्रास्ट सीटी है. ओके, एंड सो हियर आई सेड स्ट्रिंग साइन ऑफ कैंटोर है ना, कैंटोर ने बताया था, उसका नाम है यहाँ पे. ओके, And in the miscellaneous, we are now about to reach to the end of the class. We have just two images to see. We have to celebrate the end of the class. हम class का खत्म होने को celebrate करना है हमने. So to celebrate, this is a CT abdomen where you can see the colonic wall. Colon का जो wall है, वो edematous है. We are celebrating, beta. We are celebrating the end of the colonic wall is thickened and edematous. Colon का wall इतना thick है, इतना edematous है, that the contrast that we have given orally, that oral dye is seen compressed like this. Okay, so this compressed dye and the thickened wall together is looking like this musical instrument that we are trying to celebrate with. This instrument is called as accordion. इसका नाम है accordion sign on CT. Okay, so accordion में भी ऐसे fold होते हैं, वैसे ही इस colon में दिख रहे हैं because of the thick edematous wall. Okay, everybody clear? Now let's see if you can answer. Accordion sign on CT seen in. ये miscellaneous में मैंने रखा आपके लिए, इसका नाम है pseudomembranous colitis. Okay, you will read about pseudomembranous colitis in your pharmacology, microbiology, where they will talk about कौन सी drug, कौन से antibiotic से होता है, कैसे treat करते हैं. So, but keep it in mind, उसका CT appearance को ऐसा दिखता है. कोलन का wall पूरा सूजा हुआ होता है, उसके अंदर थोड़ा थोड़ा डाई दिख रहा होगा जो दब चुका है उसके कारण, and it looks like accordion. Okay, so we are trying to celebrate the end of the class with by playing some music. आपने देखा होगा in old movies Raj Kapoor would play music like this. Okay, and okay, because I see some of you are a little tired, so I thought I will leave you today. Okay, with because you are so tired, तो मैं maybe अब coffee दूध वाली दूंगा, काफे और लात दूंगा तो बात नहीं बनेगी. So what I'm giving you is coffee beans. This is what is called as coffee bean sign. What you see here is actually your dilated sigmoid colon, okay, which is converging onto left side. This is coffee bean sign of sigmoid volvulus. Coffee bean sign of sigmoid volvulus. And if I give this patient barium, if I do a barium enema, listen to me everybody, very, very important. If I do a barium enema, what will happen? The barium will go into the rectum, but towards the sigmoid, it will become narrow. Because after that, there is a volvulus. This is called as bird beak appearance or bird of prey appearance on barium enema. This is called as bird beak appearance or bird of prey appearance on barium enema. And just for a moment, I want you to imagine, okay, I want all of you to imagine with me, very, very important, okay. In the last year, in one of the exams, they asked a question, bird beak appearance on barium enema seen in. Bird beak appearance on barium enema seen in, बताओ. कई बच्चों ने मार्क किया अकलेजिया कार्डिया, क्योंकि याद करके गए थे. They had mugged up. सर्जरी सर ने बोला bird beak, barium enema, bird beak, achilles. ये भी नहीं देखा that now the barium is given via enema. If you give barium with enema, howsoever you may try, कितना भी जोर लगा लो, it cannot reach the esophagus. Okay, don't try this at home. It is very important. So this is why silly mistakes happen, because you don't read the question. Okay, do you understand this or not? This is why. Now, to end the class today, now we have to make up our mind about, okay, very, very important concept that I would now leave you in the night with you is this. So this is you. I want you to understand why most people are not able to become successful despite having potential. Because if this is your present time, okay, most people are unable to remain mindful of the current time. Mane, if they are studying in the class, their mind will always be either in the past or in the future. कि सर मेरा एग्जाम खराब हो गया तो, so they are living in future, okay, and so they are worried about future, or they are having regrets or they are just a prisoner of the past. सर मेरा PMT खराब हुआ था, सर मैं प्राइवेट कॉलेज में MBBS कर रहा हूँ, सर मैंने तो पहले कर ही नहीं पाया था पिछली बार. So most people, the problem is, instead of focusing on the present, they are either worried about the future or they are regretting or they are prisoner of the past. So what I have to do is, I want you to tell you the secret of success is, please forgive yourself for any past mistake. Forget about whatever has happened. It is beyond your control now. Okay, so let's forgive and forget the past and work for future. Because I keep seeing entire year students will keep sending me message. They will keep sending me message and say, "Sir, 6 महीने रह गए पढ़ लूं sir, हो पाएगा sir? I have not studied the entire year." So that is not in your control. That time is gone. So let's not remain a prisoner of the past. Second kind of people are the worriers about the future. Sir, पेपर खराब हो गया तो देखेंगे. आज की सोच. The only thing that you can control is your present. If you are able to focus on your present, if you are able to work hard in the present, the future will automatically be created. Okay, so stop. You have to understand, there are only things like this. Anything that you are encountering, you have to divide. Is it controllable or I cannot control? You cannot control what has happened in the past. You cannot control the future. You can control the present. So please focus all your energy on present. That is why it is called as a present, because it is a gift. So please focus all your energy on present. Everything will happen. Okay. I wish you all the best. In the next class, I will cover up with the mammography, a little bit part of today's class which is left, which is mammogram, and we will go on to radiation physics. Thank you very much. See you in the next class. Good night.